Hello everybody and welcome back to Emergency Medicine Quest. In this video we will go over CNS infections which are not an uncommon presentation to the ED. The two most common CNS infections are meningitis and encephalitis, which we will talk in detail. Before that, make sure to like, share and subscribe to the channel for more such content. Every ED physician should be well aware and well educated about CNS infections because they carry a significant morbidity and mortality. Meningitis and encephalitis are not mutually exclusive. Meningitis is the infection of the meningeal layers that is present between the bony covering of the CNS and the brain tissue, and encephalitis is the infection of the brain parenchyma. Since medical school, we are aware that meningitis and encephalitis have multiple etiologies, including bacterial, viral, fungal, TB. So, in bacterial meningitis, there are certain bacteria that we must be aware of. So, the most common bacteria causing meningitis in adults is strep pneumonia. Neisseria meningitidis is seen usually in children. Listeria is seen usually in the extremes of age, so it can be seen in elderly or it can be seen in infants. And normally neonates, that is up to 6 weeks of their life, the most common organisms is represented by GBS and or E. coli. Generally, the mortality from bacterial meningitis is quite high, but the highest fatality rate is normally seen with listeria with a mortality rate of 27%. As for viral meningitis, the most common causes are usually enterovirus or herpes virus. The prognosis remains to be really good in such cases. As for fungal meningitis, we know the most commonly implicated organism is Cryptococcus, and normally it is the immunosuppressed patients who are more prone to fungal meningitis. The mechanism of infection in fungal meningitis is basically initially there is a pulmonary exposure that is followed by a spread in the blood. The fourth etiology of meningitis is TB. So we know that mycobacteria goes to the CNS via blood and it will start forming granulomas. The same set of organisms that are responsible for viral meningitis are also implicated in viral encephalitis. One thing to bear in mind with viral encephalitis is the mode of transmission, and one of the common mode happens to be via vectors. What is important about viral encephalitis is to know what organism has got the highest mortality rate and the rate of neurologic sequelae among those who survive. So we have our Japanese encephalitis virus, we've got Eastern equine virus, and we've got St. Louis virus. The other thing to know is which virus causes encephalitis, particularly in those who are immunocompromised with HIV or other pathology. So it is CMV. The final category of serious CNS infection that we will talk about is brain abscess. Normally, brain abscess happens by two main pathology. One is by spread in the blood from a remote infection, and the other is a contiguous invasion. If there is a contiguous spread, then normally the location of the initial infection dictates where the abscess will be. So if the infection was, let's say, otitis media and then a person developed a brain abscess secondary to that, then they will have an abscess in the temporal lobe or in the cerebellum, and if it arised from a sinusitis, then it will be seen in the frontal or the temporal lobes. Hematogenous spread on the other side normally causes multiple brain abscesses. The risk factors of brain abscess is normally IV drug use, neurologic surgery, and cranial trauma. The spinal epidural is one of the common sites of CNS abscess, and it is highly associated with IV drug use or CNS surgeries. Now let's discuss the clinical features of each of the categories we discussed. Meningitis, regardless of whether it's bacterial or viral, comes with fever, headache, photophobia, nuchal rigidity, but normally in an immunosuppressed person or in a geriatric person, the only presentation finding can be an altered mental status, and in neonates, it can be decreased tone or weakness and changes in behavior. Once again, from medical school, we know that the two classic presentations in terms of examination of meningitis is Koenig and Brudzinski, but recent studies have shown that these only have a sensitivity of 12%. And when a patient comes with meningitis, it is imperative to search for the location of inciting infection, whether it's a skin abscess, whether it's sinusitis, whether it's otitis, whether it's osteomyelitis. Once again, in encephalitis, it can occur from any of the etiology, whether viral, bacterial, fungal, and it is not possible for us to differentiate the etiologies based on history or physical examination. The diagnosis of encephalitis requires an altered mental status or behavior with fever, headache, seizures, disorientation. Sometimes, if the encephalitis is in a particular lobe, that can also determine the kind of manifestations. So, if the encephalitis is in the frontal lobe, then the person is going to come with abnormal behavior, psychosis, hallucination. As for an abscess, the most common finding is a headache. Fever can be present but may not also be present. Same can be said of an altered mental status. Some of these patients can present with seizures, neurologic deterioration, death. If the abscess is present in the epidural space, then the most common presentation they will come with is a midline pain. There's a very nice table in Rosen's that you can refer to that mentions what is the sensitivity and specificity of certain clinical findings and examination findings in patients with suspected meningitis. And we see that the highest sensitivity in a symptom or a sign is headache at 91% sensitive for meningitis, and the highest specificity is seen with Brudzinski sign at 98%, but it is not very sensitive. Moving on to diagnostics of CNS infections, so no test substitutes an LP. Relying on complete blood count is not a good idea because it is often non-specific, and having a normal leukocyte in a CBC does not rule out a CNS infection. Certain doctors recommend the use of procalcitonin. It has a sensitivity of 90% and specificity of 98% when we are discriminating or distinguishing between a bacterial or viral etiology of a CNS infection, but obviously it does not rule in or rule out a CNS infection to begin with. Any patient in which we are considering to perform a lumbar puncture, remember to always have a look at their coags, because you don't want to be performing a lumbar puncture, especially if they are at high risk of bleeding. A very important test to send for in CNS infections is blood cultures. This should be done as soon as possible. However, even if you have given antimicrobial therapy, you should still send for it because it can identify the pneumococcal and meningococcal infections. In terms of imaging, a CT head without contrast or an MRI is helpful. A question may arise, when do we send for a CT with contrast? So normally prefer to send a contrast study when you have a mass lesion on your differential. So if you're suspecting a CNS abscess, then you can send for a contrast enhanced CT. Although in both cases, MRI is the more sensitive test, a bedside ultrasound looking at optic nerve sheath diameter is also a great test to evaluate for increased intracranial pressure. A diameter more than 5 mm is diagnostic for an increased intracranial pressure. This is particularly useful if the ED physician is not very confident with a fundoscope. Let's talk about a lumbar puncture in more detail. So as we discussed, a lumbar puncture for CSF analysis is indicated whenever we suspect a CNS infection, unless there is an infected puncture site or there is a risk for brain herniation. Although the literature says that coagulation studies do not need to be routinely obtained before getting an LP, but in reality most physicians would consider getting it regardless of a history of coagulopathy or anticoagulation or not. A platelet count of less than 40,000 should defer us from performing an LP. An INR of more than 1.4 in a person with warfarin should also defer us from performing an LP. If we suspect that the patient has got increased intracranial pressure and hence herniation is a risk, then that also is a contraindication to performing LP. So if you see the presence of papilledema, if you see increased optic nerve sheath diameter on ultrasounds, if you perform CT and you see mass lesions or any other signs of increased ICP, then that should delay an LP. One of the important consideration with LP is that once you give antibiotics, the CSF gets sterilized within an hour. But that being said, you should not delay giving antibiotics for an LP. Some of the parameters of LP is as I've written in this table. So we've got something called as opening pressure. The normal upper limit of CSF pressure is about 20 centimeter water. This is something you need to give an attention to if the person is lying recumbent, because if the person is sitting, then we do expect that the opening pressure is going to be slightly more increased. The idea behind opening pressure is that it is often elevated in meningitic infection, but we don't have enough data to comment on the sensitivity or specificity of this, as when we perform an LP, at least 3 sterile tubes, each containing 1 ml to 1.5 ml of CSF should be obtained. You can keep a 4th tube also ready in case of any additional studies later on. So when you look at the CSF, you should look for any turbidity, any cloudiness. Normal CSF is often clear, colorless, and you cannot distinguish it from water. So any level of turbidity is indicating some form of pathology. Regarding the cell count, the normal adult CSF does not contain more than 5 leukocytes. In the analysis, if there is evidence of more than 5 cells, 5 leukocyte cells, then that is an evidence for CNS infection. Often in bacterial meningitis, we will see that the cells would be in anywhere to 1000 to 2000 range with a neutrophilic predominance. Lymphocytosis may be seen in viral or even in some cases of bacterial meningitis. Remember that even if your CSF cell counts are normal, they do not exclude bacterial meningitis, especially if the patient has risk factors of immunocompromised state. A gram stain will identify the causative organism in about 75% of the cases in bacterial meningitis. But remember, as we spoke earlier, if the antibiotic has been started prior to the LP and the elapsed time is ranging from 1 hour post giving of antibiotics, then the yield is going to be diminished. The CSF glucose levels is normally 2/3 of the serum glucose. So we can say that it is usually in the range of 50 to 80 milligrams per deciliter. Increased CSF glucose is normally seen in bacterial meningitis. Normal CSF protein in an adult is less than 45 milligrams per deciliter. So once again, an elevated CSF protein is seen in bacterial meningitis. There are other parameters also that come into the picture when we are discussing an LP analysis, and one of which is xanthochromia, which is the yellowish discoloration of the CSF. Xanthochromia is an abnormal finding and often sensitive for subarachnoid hemorrhage. Why it happens is because the RBC breaks down the pigments. An India ink stain of CSF was often used to diagnose Cryptococcus meningitis. It was historically used as a rapid means of diagnosis, but recently we've seen that it has very poor sensitivity, especially in non-AIDS patients. So we can do a cryptococcal antigen testing if we're suspecting a cryptococcal infection. We can send for acid-fast bacilli staining if we're suspecting tuberculous meningitis, but again this also has poor sensitivity. To summarize, the opening pressure is increase in bacterial and fungal or TB infections, but can remain normal in viral. As for the protein, it is once again increased in bacterial, but may be normal or may be increased in both viral and fungal/TB. As for glucose, we see a decrease in the bacterial infection, remains normal in viral, and it may be normal or may decrease in fungal or TB. Gram stain will obviously only be positive in cases of a bacterial infection. WBC count is markedly elevated in cases of bacterial infection but may be moderately increased in viral and fungal. The predominant cell in a bacterial meningitis is neutrophil, whereas in viral it's lymphocyte, and in fungal or TB can either be lymphocyte or neutrophil. Finally, on to the last bit of this lecture, which is the treatment of CNS infections. Specifically, if we talk about meningitis, encephalitis, remember to start antibiotics as soon as possible. Here's a little box to guide which antibiotics to use. Obviously, until the causative organism is identified, broad spectrum coverage is indicated. In neonates, as we discussed earlier, GBS and E. coli are the most predominant organisms, hence we go for ampicillin and cefotaxime. In neonates, ceftriaxone should be avoided, especially since a lot of them present with hyperbilirubinemia, and ceftriaxone tends to displace bilirubin from albumin and hence increases the bilirubin levels further in the blood. That is why we prefer cefotaxime instead. In infants, strep pneumonia and Neisseria meningitidis is the most prevalent organism, and hence we go for either ceftriaxone or cefotaxime. In adults, the same set of organisms are implicated, and once again we go for the same cocktail of either ceftriaxone or cefotaxime with an addition of vancomycin to cover for any resistant organisms. In the elderly, because listeria gets added to the worrying set of organisms, hence the cocktail of adult plus high-dose ampicillin is added to the treatment plan. Generally, ceftriaxone is given at the dose of 2 grams and high-dose ampicillin also at the dose of 2 grams. Cefotaxime is also given at the dose of 2 grams in adults, and vancomycin is given at the dose of 25 to 35 milligram per kg in adults and elderly. In case a patient is allergic to cephalosporins, meropenem or chloramphenicol can be used. The guidelines also advise us to use corticosteroids to decrease the mortality in patients with pneumococcal meningitis, and corticosteroid decreases the incidence of hearing loss in patients. Naturally, if tuberculous meningitis is suspected, then we start them on the RIPE regimen, and if fungal meningitis is considered, then we can start them on amphotericin B. Viral meningitis is mostly covered by acyclovir at the dose of 10 mg per kg. Naturally, early cases of viral meningitis is indistinguishable from bacterial, and generally this combined cocktail of antibiotics and antiviral is given along with corticosteroids. The management of CNS abscess depends on the location, size, number of abscesses, because that will help us determine if a medical management is needed, surgical excision is needed, or aspiration is needed. Generally, in ED, neurosurgical consultation should be obtained as soon as possible for determining what sort of intervention is needed. It is imperative we also talk about prophylaxis and antibiotic dosing for certain organisms. So, Neisseria meningitidis requires the close contacts, that is, normally roommates, partners, daycare workers, or any healthcare workers exposed to secretions, particularly if they're intubating, to receive some form of prophylaxis. Now, this can either be done with ciprofloxacin or it can be done with rifampicin. In a similar manner, H. influenza also requires prophylaxis, but this time for immunocompromised children or unvaccinated children less than 4 years old, and this also requires rifampicin.